Hi there. This video I'm going to explain to you how a cholecystitis, which is inflammation of the gallbladder, can occur. Most often this occurs because of gallstones, bile stones. So a little bit of physiology here. We have the liver. The liver contains hepatocytes, and these hepatocytes secrete biliary fluid into biliary canals. And we have a right hepatic duct and a left hepatic duct, which converge into a common bile duct, which then empties into the duodenum. Now, this common bile duct, it has an opening, and this opening leads towards the cystic duct, and the cystic duct is connected to the gallbladder. Now, the normal flow of biliary fluid is in this direction, so from the hepatic ducts to the common bile duct, and between the gallbladder and the common bile duct, the flow of bile is bidirectional. So it can either go to the gallbladder or go from the gallbladder. When someone eats, the gallbladder, which stores biliary fluid secreted by hepatocytes, the gallbladder contracts, it empties, and then the bile enters the duodenum, where it will emulsify the fats that have been consumed, so that these fats can be dissolved in the chymus and can be absorbed. Now, how does a cholecystitis, inflammation of the gallbladder, occur? Most commonly, it's because of a stone. And so, again, I'm going to draw the biliary anatomy, gallbladder, cystic duct. Here we have the left hepatic duct, right hepatic duct. This is the common bile duct. Now, let's say there are two stones. Now, how do these stones form? They form in the gallbladder, where biliary acids can precipitate because their concentration is too high, or because the gallbladder hasn't emptied for a while. And these stones form because of precipitation of biliary acids, of which the concentration exceeds their solubility. Now, these stones, when you see them in the gallbladder, this is called cholecysto, which means sac, lithiasis. Now, on itself, this is usually asymptomatic. These biliary stones, they may sometimes irritate the gallbladder wall, and someone may have some episodes of pain, but usually this is asymptomatic. The problems occur when one of these stones migrates into the cystic duct or into the common bile duct, because what will happen is biliary fluids will not be able to be passed on to the duodenum, and so there will be buildup of biliary acids. And what it's going to look like, it's going to look like this. So first of all, the bile ducts are going to dilate. Proximally to the stone. So here's the stone, and the ducts proximal to the stone are going to dilate, and distal to the stone, it's going to be small as usual. And also the gallbladder is going to become enlarged, because these biliary fluids, the elevated pressure is going to distribute between the biliary canals and the gallbladder. So there is increased pressure on the gallbladder wall. What we must realize, what is really important to realize, is that the gallbladder wall is continuously secreting mucosal secretion. So it's not just bile that's in the gallbladder, it's also mucosal secretion. So even if you have a stone that obstructs the cystic duct, you may logically infer from this that, well, the gallbladder will not enlarge because bile cannot enter into the gallbladder. This is erroneous. It's understandable, but erroneous, because the gallbladder will continue to secrete mucus, and this mucus cannot escape the cystic duct. All right. So we have an obstructing stone. The biliary ducts are increasing in caliber. The gallbladder is increasing in caliber, and this is called hydrops. Hydrops. Ultrasonographically, what you'll see is a highly dilated gallbladder, and you cannot compress it. So when you hold your ultrasound probe against the gallbladder, you cannot compress it. You can't flatten it because the pressure is so high. Now, there's a big problem with hydrops because inside the wall of the gallbladder, there are blood vessels. And these blood vessels, if you compress them, which is what happens when you have hydrops, you compress them, and what you get is ischemia. And this ischemia, what it does, it renders the gallbladder wall more vulnerable. So instead of, I'll draw the gallbladder wall now, instead of a continuous line, I'll draw it as a dashed line. It's more vulnerable because of the ischemia. This vulnerability is paired by inflammation. So I'll draw a flame. Where you have ischemia, you have inflammatory response. The problem here with this is twofold. One, you may get bacterial infection, opportunistic infection, and one is you may get perforation. So bacteria, they may enter the biliary fluid, they may ascend into, via the bile ducts into the gallbladder. Usually they won't cause an infection. But if the gallbladder wall is so damaged due to this bile stone, due to this dilatation, due to this vulnerable wall, you may get infection. So you get a bacterial infection, which will further contribute to the vulnerability of the gallbladder wall. And if this is not treated by a cholecystectomy, antibiotics, or a cholecystostomy, where an interventional radiologist may percutaneously place a tube that will evacuate biliary fluid from the gallbladder, if all this doesn't occur, there's no treatment, then what will happen is you will get a perforation. So the gallbladder will just perforate, and all the mucus and biliary secretions will release into the peritoneal compartment. And in the peritoneal compartment, as a result, you may get free air. So there's O2. I'll draw a little cloud. And if it's infected, you will also get bacteria. And this is a problem because peritoneum is normally sterile. It's not built to accommodate bacteria. So what you will get is a peritonitis. And a peritonitis is inflammation of the peritoneal compartment. And as we know, the peritoneal compartment has a outer layer and an inner layer. And this outer layer is called the parietal peritoneum. Inner layer is visceral peritoneum. So this is parietal, and this is visceral. And normally there's only a little bit of fluid, peritoneal fluid here. Now there are bacteria, it's causing inflammation. And as a patient moves, this parietal and visceral peritoneum, when they move, slide over each other, this is going to cause a lot of pain in a patient with a cholecystitis or even a perforated cholecystitis. So there will be a tendency to lie still, very still, which is characteristic of not only cholecystitis, but many inflammatory diseases such as appendicitis and diverticulitis. So you may see in a perforated cholecystitis, you may see free air, you may see infection. And one tendency that the immune system has a tendency to encapsulate bacteria, to protect the body against these bacteria. So what you will get is you get a thick wall that surrounds bacteria. This thick wall consists of a fibrous capsule that's made by the immune system, and inside you will have pus. Now, the good thing about this, which is called an abscess, is that it protects against further bacterial spread. That's the entire purpose of an abscess. The problem is that it's very difficult to get rid of an abscess by antibiotics alone. So this is an indication for either percutaneous drainage of the abscess using a pigtail drain, for instance, or if it's not accessible percutaneously, for instance, if this abscess is behind a intestinal loop or proximal to a big vessel, there's an indication for surgical evacuation. So in summary, we've talked about the pathophysiology of a cholecystitis and complications that may occur because of a cholecystitis. Important key points is we need to realize that the gallbladder wall secretes mucus. So if there is an obstruction of gallbladder outflow, you will have an increase in pressure in the gallbladder because the mucus cannot be released. This increase in pressure will lead to increased pressure on the gallbladder wall, which will compress vessels, which will lead to ischemia, which will lead to inflammation, which will lead to a more vulnerable gallbladder wall, which will lead to opportunistic infections, which further contributes to the vulnerability of the gallbladder wall, which will lead to perforation, spread of pus into the peritoneal compartment, a peritonitis, maybe abscesses, and the target of treatment of a cholecystitis is to prevent this from happening, which in most cases requires a cholecystectomy and antibiotics. And if a cholecystectomy is not possible, a cholecystostomy may be performed where a percutaneous drainage of the gallbladder is achieved. I hope you enjoyed this video, and see you on the next one.